Welcome to FHIR Basics for Post-Acute Care. The purpose of this presentation is to provide information for a non-technical audience about FHIR technology and terminology with a focus on post-acute care, including what is FHIR, what is an application programming interface or API, what is HL7, how are the Centers for Medicaid and Medicare Services and ONC supporting the use of interoperability standards, including policy initiatives and the PASSIO project. For technical experts, we hope this presentation also provides some helpful analogies you might find helpful in communicating those concepts to others new to FHIR. Next slide. I don't usually read all the text on a slide verbatim, but in this case, it is important for everyone to have a common baseline understanding of some key terms. Some key terms in interoperability include clients, which refer to software that connects to another system, and servers, a computer system the client connects to or interacts with. Another key term that you will hear often is use case, which is a hypothetical scenario that illustrates a problem by providing clinically relevant details about a patient and defining the interactions between the patient and healthcare. A use case example would be a patient with multiple chronic conditions, for example, diabetes, depression, rheumatoid arthritis, and hypertension, experiences a fall and is admitted to a hospital for hip surgery. Upon discharge from the hospital needs to share the patient's medication instructions with a skilled nursing facility. Prior to hospital admission, the patient was taking metformin 500 milligrams twice a day, fluoxetine 20 milligrams once a day, a Humira self-injectable pen biweekly, and lisinopril 10 milligrams once a day. The hospital prescribed additional hydrocodone at 5 milligrams and 300 milligrams acetaminophen twice a day for 10 days. These details are critical to ensure that the technical solutions satisfy real-world needs. An implementation guide provides instructions for developers on how to design and implement technological solutions to achieve the goal identified in the use case. For example, an implementation guide might provide instructions for what information to include and how it should be structured when a patient transfers from a hospital to a skilled nursing facility. For example, in addition to the list of medications, it is also important to include the dosage, frequency of administration, when the medication was last administered, date the medication was started, date the medication should cease to be administered if applicable, the method of administration, tablet by mouth, IV, self-injection, the order in which the medications appear, whether it should be alphabetical by drug name, by drug class, etc. The IG specifies whether some of this information is required for all patients transitioning from hospitals to skilled nursing facilities, and whether some of this information might be optional or only if applicable. An implementation is the technological solution developers design using the implementation guide as a template. So this could be, for example, a mobile application. An example implementation would be a specific hospital that uses an implementation guide as a template to update the way its information is represented in its EHR so that it is consistent with how other hospitals represent the information in their EHRs and compatible with the SNF EHRs so that it can receive the information. Because the hospital has an internal quality initiative to track all opioid prescriptions to ensure that extra precautions are taken and the prescription is not filled beyond the post-surgical window, they enable an optional feature that displays a pop-up message indicating that the prescription for hydrocodone should be discontinued after 10 days. So once the implementation guide has been created, there might be testing during a connect-a-thon, which provides an opportunity for multiple vendors to review the implementation guide, test the client and server software in a structured environment, and provide constructive feedback. It can be described as a test kitchen and the implementation guide as a recipe that can be refined by all the participants. Several EHR vendors at a connect-a-thon for various hospital systems and skilled nursing facilities can get together and share their implementations to make sure they all interpreted the IG consistently and produced compatible implementations, such that each of their individual health IT systems can connect with each other and successfully exchange all the information in the IG. They might identify gaps in the IG where additional clarification would be helpful. They can also share if they use the template to develop optional features. For example, the pop-up window when the patient has been prescribed an opioid. In other words, some of the vendors may add chocolate chips or walnuts or dried cherries to customize the recipe for their consumers. Data elements are the most granular level at which a piece of data is represented. For example, a brief interview mental status or BIMS total score, gender, insulin dosage, systolic or diastolic blood pressure. Data elements are the ingredients that go in the recipe. A value set defines the possible values for a group of data elements represented by a set of codes from one or more code systems. For example, LOINC codes, CPT codes, ICD codes that can be used and reused to exchange data between systems. The value set can tell you where to find the ingredients and what quantity they should be used, or not the quantity, but the unit of measurement to use. Next slide. So in sum, our key analogies for baking in FHIR are that an implementation guide is like a recipe, the cake is the implementation, and a connectathon is the test kitchen. So what is FHIR? FHIR, which stands for Fast Healthcare Interoperability Resources, is a standard for exchanging healthcare information electronically. Standards establish a common language and process for all health information technology systems to communicate, allowing information to be shared seamlessly and efficiently. Healthcare records increasingly are becoming digitized as patients move around the healthcare ecosystem. Their electronic health records must be available, discoverable, and understandable. The philosophy behind FHIR is to build a base of set resources that either by themselves or when combined satisfy the majority of common use cases. FHIR can be used as a standalone data exchange standard or with existing standards such as CCDA. FHIR is free to use and uses mainstream web technology. Next slide. So the problem with standards is that stakeholders often have both common and differing needs, and creating one standard to fit all would be too slow and too large. Everyone needs to adopt the same standard in spite of these challenges. FHIR is not the first health IT standard. Others have included CCDA, QRDA, et cetera, but other standards failed to achieve widespread adoption across industry. FHIR is informed by years of lessons around requirements, successes, challenges gained through defining and implementing previous standards. FHIR aims to simplify implementation without sacrificing information integrity. It leverages existing models and ensures alignment to previously defined best practices to provide a consistent, easy to implement, and rigorous mechanism for exchanging data between healthcare applications. A FHIR resource broadly identifies characteristics that define a concept or category, such as an observation, a patient, or a condition. R4, the most current version of FHIR, consists of 143 predefined resources. These resources increase reuse of data for multiple purposes and enable lighter weight communication by pointing to existing resources rather than sending all data, facilitating real-time updates. Resources in FHIR are somewhat generic because they have to be usable in different countries and by different types of clinicians. Recognizing that a one-size-fits-all approach is not appropriate in the healthcare space, FHIR also provides the ability to adjust the resources to be able to handle the different needs implementation spaces define using profiles and extensions that enforce constraints. Resources are designed in a way that these changes can be made without changing how systems pass information around, whether or not those additional elements are used by the receiving system. So back to our baking analogy. A resource is a template that broadly identifies characteristics to define a concept or category. So in our baking example, one resource might be cake. Cake consists of cake flavor, which could be described as chocolate, yellow, carrot, marble, etc. Icing, which could be ganache, buttercream, cream cheese, toppings such as sprinkles, walnuts, raspberries, raisins, and Oreo cookies, and number of tiers, 1, 2, 3, etc. A profile would customize a resource to allow specified constraints. So you could develop a profile using the cake base resource called chocolate cake. And for this chocolate cake profile, it would constrain the following requirements. The cake flavor must be chocolate. The icing must be ganache, buttercream, or raspberry jam. Toppings may be any of many or none, and tiers must be 1, 2, 3, or 4. An extension adds characteristics to a profile that are not part of the base resource. For example, you could create an extension to the cake resource for the shape of the cake, round or square, and the size of the cake, 6 inches, 8 inches, or 10 inches. Balancing the competing needs of promoting consistency while retaining flexibility can be a challenge when authoring an implementation guide. The same end could be achieved using many different methods, which is why the use case development process is so vital. For example, the chocolate cake profile could be broadly specified to allow for maximum customization, or very narrowly specified to ensure that everyone's cake turns out exactly the same. The chocolate cake profile displayed above takes a middle of the road approach. You could instruct a profile specifically for German chocolate cake, which would add further constraints, such as cake flavor must be chocolate, icing must be chocolate, toppings must be coconut and pecan, and tiers must be 2. But then if you don't like coconut or you want to add anything else, that wouldn't be possible using this profile. You would need to create a new profile. Alternatively, you could create a German chocolate cake using the chocolate cake profile. However, when you leave the constraints more open-ended, you accept the possibility that someone might decide to put onions and mushrooms on their chocolate cake. An implementation guide could consist of one profile or multiple related profiles. For example, the birthday cake implementation guide could include profiles for chocolate cake and yellow cake, each having its own constraints, but both built using the cake resource. An implementation guide could also contain profiles built on more than one resource. For example, the birthday party implementation guide could include profiles for chocolate cake and yellow cake based on the cake resource, and also include profiles for party hats based on a decorations resource. A resource also can include reference to another resource. For example, icing could be a characteristic of the cake resource and also be its own base resource in and of itself. The characteristics of the icing resource might be, for example, sweetener, including sugar, corn syrup, dextrose, etc., color, pink, green, white, etc., cream, cow's milk, coconut milk, butter, cream cheese, etc. Next slide. An instance is each implementation of the profile, or each cake baked using the chocolate cake recipe. 2 implementers could use the chocolate cake profile to create 2 very different cakes as pictured above. Next slide. Applying our analogy to help understand the Passio functional status IG, we can take prior level of function profile as an example. Our resource that we used for the prior level of function example is observation, with the following characteristics: effective date and time, code, value set, text, performer to indicate who is responsible for the observation, and subject referring to the patient resource. The profile is for prior level of function includes the following constraints. Must include effective date time, must include fixed, the LOINC code 10158-4, history of functional status narrative, may include value or no value, must include text summary of prior level of function for the patient, must include performer, and must include subject, which will refer to the patient resource. The prior level of function profile also includes an extension for where the assessment occurred and for whether or not assistance was required. Of note, the Passio Functional Status Implementation Guide actually includes 5 profiles: Passio Functional Questionnaire Response, Bundled Functional Status, prior level of function, and use of device. Each profile uses one or more resources, observation, questionnaire response, or device use statement, to specify what information to include and where to get that information. Some of these resources also include references to other resources, such as patient or provider information. Implementers can customize one or more of these 5 profiles to communicate comprehensive or only select information about a patient's functional status. So to recap, resources are the building blocks of FHIR. Each resource is a standalone, meaningful piece of information, but the resources also can refer to other resources to form a full network of information. Next slide. As of 2015, 87% of hospitals already were using certified FHIR EHRs, and that number has only been growing rapidly. Although PAC may have a bit more work ahead to reach a critical mass of FHIR adoption, one goal of PASIO is to raise awareness that FHIR can provide more efficient and secure access to patient health information while reducing provider burden and improving care coordination. PASIO also develops IGs to help adoption of FHIR technology as easy as possible for providers and their vendors. What is an API? An API, or an application programming interface, is software that allows 2 systems to talk to each other using a request and response format. It enables the retrieval or exchange of only specified information from a large amount of data. For example, when you order a pizza, you don't have to specify all the toppings you don't want. You simply specify what you do want, and the API in this example would fetch your pizza, including only those items. So what is a FHIR API? FHIR APIs leverage the same standards as web browsers to reduce bandwidth requirements. They reduce miscommunication and impediments to communication between systems by establishing a common language and protocol, or directions, for how system exchanges data. Systems need to use the same dictionary, language, terminology, and alphabet to exchange information accurately. Computer systems need all these layers to align in order to communicate with each other. French and English, for example, share the same alphabet, but 2 people speaking different languages still won't understand each other. Even English spoken in Great Britain and American English may not align on terminology. There is also a need to use the same directions or protocol. If 2 people are going to the same address and one takes the highway but the other takes back roads, they may not arrive at the same time. What is HL7? HL7, founded in 1987, is a not-for-profit, nonpartisan, membership-based American National Standards Institute accredited standards developing organization. HL7 provides a comprehensive framework and related standards for the exchange, integration, sharing, and retrieval of electronic health information that supports clinical practice and the management, delivery, and evaluation of health services. Balloting is the formal process that HL7 uses to vet specifications prior to publication. The objective of balloting is to seek feedback on a proposed standard to ensure that the community that will be governed by that standard is in agreement with the expectations set by the standard. Prior to balloting, IG developers must, 1, gain sponsorship from at least 1 out of the 37 HL7 work groups, 2, participate in at least 1 connectathon, and 3, have at least 3 reference implementations. It is important to note that the requirements for HL7 may evolve over time, and these are the current state requirements for ballot. HL7 members have voting rights in HL7 ballots, and non-HL7 members may also participate with an administrative fee, including strict instructions. Non-members can still submit comments through the JIRA system, though they do not count toward the official ballot totals. There are several HL7 balloting levels. The first is the 4-comment ballot. It has the least onerous requirements in terms of response to feedback. There isn't really a notion of pass or fail for informative ballots either. Used early in the development cycle to solicit feedback from the community, they are intended to give guidance and direction to the work group developing the specification to solicit before soliciting review by the community. The second level is informative, which is primarily used for specifications that guide internal HL7 processes or ones that provide recommendations or guidance to the implementer community. The third is standard for trial use, STU. It is used to vet content that will eventually be binding on implementers and for work groups who have limited implementation experience. Content development is sometimes done in iterations, especially if there are significant changes. Each iteration is labeled as STU 1, STU 2, STU 3, etc. This is the type of ballot that the PASSIO project is pursuing right now. Lastly, we have the normative ballot, which is used for the final review of specifications and are binding on implementers. The specifications that result from this are considered authoritative. This is the gold standard with what we hope to achieve eventually. One of the key aspects of the normative standard is that all subsequent modifications must be backward compatible, which is not the case with the STU standards. HL7 requires standards submitted for normative balloting to have at least 5 production implementations. The balloting process starts with STU ballot preparation, which consists of submitting a project proposal for acceptance by the HL7 community. Next, submission of the project scope statement to a sponsoring work group for approval. Then gaining approval of the project scope statement from the US Realm Clinical Steering Division, FHIR Management Group, and Technical Steering Committee, or other committees as applicable based on the content of the project scope statement. Complete work proposed in the PSS, which in many cases might be an implementation guide. Complete 3 vendor implementations of the IG through participation in connectathons, and gain approval of the completed work proposed in the PSS from the FHIR Management Group. Finally, submitting a notice of intent to ballot, which will be done by the sponsoring work group on behalf of the developer. Then the ballot is open for voting. Finally, there is a post-ballot comment period during which a decision is made to approve or not approve. Affirmative to negative ratio must be at least 60% to publish as STU 1. If that threshold is not reached, voters must rescind their negative votes. Even if the threshold is reached, every single comment must be addressed to the satisfaction of the sponsoring work group before the standard may be published. Here you will see an example timeline for HL7 balloting. Generally, a project scope statement needs to be approved at least 7 to 10 months prior to submitting a notice of intent to ballot. And there are many interim steps along the way. How are CMS and ONC supporting the use of interoperability standards? Stakeholders consistently provide feedback to CMS and ONC about opportunities for improvement related to health information exchange during patient transitions of care. Specifically, the current state presents challenges including poor communication across care providers, reliance on patient recall during periods of high stress or when patients may be unconscious or otherwise unable to communicate information, an increased cost and provider burden related to hospital stays from adverse events, readmissions, and additional administrative costs to locate, reconcile, and coordinate information. CMS and ONC also have engaged with stakeholders through technical advisory groups, requests for information in various rules proposed through the Federal Register, and other formats to identify how interoperable health data, and specifically post-acute care assessment content, could improve care coordination between multiple providers, proxy or family members, transitions of care referrals, admission or discharge information notifications, population health management, changing relationships between patients and caregivers, provider engagement, and advanced directives. There have been some specific CMS and ONC policy initiatives over the past few years. A few highlights from one of the largest, the CMS Interoperability and Patient Access Final Rule, which was released in tandem with the 20th Century Cures Act, includes the following highlights. The Patient Access API which is a regulation that CMS payers are required to implement and maintain a secure FHIR API that allows patients to easily access their claims and encounter information. A provider directory API, in which CMS regulated payers are required to make provider directory information publicly available via FHIR API to encourage innovation by allowing third-party application developers to access information so they can create services that help patients find providers for care and treatment, as well as help clinicians find other providers for care coordination in the most user-friendly way possible. A payer-to-payer data exchange requirement, in which CMS regulated payers are required to exchange certain patient-level clinical data, specifically the US Core Data for Interoperability, US CDI version 1 dataset, which I'll talk more about on the next slide. At the patient's request, allowing the patient to take their information with them as they move from payer to payer over time to help create a cumulative health record with their current payer. Improving the dually eligible experience by increasing the frequency of federal state data exchanges, updating requirements for states to exchange certain enrollee data to individuals dually eligible for Medicare and Medicaid from monthly to daily, ensuring beneficiaries are getting access to appropriate services while eliminating waste and burden. Public reporting and information blocking, which will require CMS to publicly report eligible clinicians, hospitals, and critical access hospitals that may have been involved in information blocking to inhibit interoperability. Digital contact information, in which CMS will begin publicly reporting those providers who do not list or update their digital contact information in the national plan and provider enumeration system to facilitate care coordination and data exchange in an easily accessible format. And finally, admission, discharge, and transfer event notifications, in which CMS is modifying the conditions of participation to require hospitals, including psychiatric hospitals and critical access hospitals, to send electronic patient event notifications of a patient's admission, discharge, and/or transfer to another healthcare facility or to another community provider or practitioner to improve care coordination. Although post-acute care entities have not been included in these rules, it does provide a framework to lay the foundation for interactions across the healthcare continuum. As I mentioned in the previous slide, the United States Core Data for Interoperability, or the US CDI, is a standardized set of health data for nationwide interoperable health information exchange. The US CDI includes a series of data elements, the most granular level at which a piece of data is represented in the US CDI for exchange, and their component data classes, which are grouped by common theme or use case. The ONC Cures Act requires, as a condition of certification, that EHRs adopt the US CDI standard as a standardized FHIR API for patient and population services, which includes an initial set of 16 data classes comprised of 52 data elements. Future expansions to the US CDI could also include data elements extracted from post-acute care assessments. Some already are under consideration and undergoing public comment process. The figure on this slide is a screenshot of the US CDI data elements from healthit.gov. The Trusted Exchange Framework, as described in the ONC 21st Century Cures Act, also requires the development of a trusted exchange framework or a common agreement for the exchange between health information networks with the goals of providing a single on-ramp to nationwide connectivity, securely following the health information as needed, and a nationwide scalability. The ultimate intent is to unify disparate health information exchange. Ultimately, it is intended to unify disparate state-level health information exchanges. And this is why we are all here today, the PASSIO project. Established in February 2019, the PASSIO project is a collaborative effort between industry, government, and other stakeholders with the goal of establishing a framework for the development of FHIR implementation guides to facilitate health information exchange. This slide illustrates the process by which PASSIO works with HL7 to recognize its work developing IGs as standards. First, developing a FHIR implementation guide and reference implementations validated by the HL7 community that vendors will build into their system, ultimately providing a standardized method of exchanging health information across healthcare settings. The PASSIO project's ultimate goal is to develop a framework for health information exchange, next slide, that provides a complete transfer summary as a patient transitions between care settings. Taking a stepwise approach, PASSIO is tackling smaller content areas that comprise the transfer summary by focusing on specific use cases. The PASSIO project initially identified the areas of functional status and cognitive status as areas of clinical importance in need of the most immediate standardization. Functional status and cognitive status IGs are currently in the STU1 ballot process, the final step in the standards approval process before community adoption. The PASSIO project recently has begun developing use cases for advanced directives, speech-language pathology, and reassessment time points. The PAC assessment questions and responses options within the CMS data element library were used as a foundation for the existing PASSIO IGs, and the workgroup constructed a use case for the exchange of patient data as a patient transitions through multiple care settings, including home and community-based services, acute care, post-acute care, and including patient family access to health information. During the May 2020 HL7 Connect-a-thon, the HL7 clinical reasoning track also integrated existing FHIR quality measure standards with the PASSIO IGs to confirm interoperability and ability to calculate the measures using PASSIO IGs. The clinical reasoning track participants used sample data successfully to convert the data model to FHIR and execute the selected ECQM CMS-149V9 dementia cognitive assessment and successfully obtained the numerator and denominator results. The clinical reasoning track also used the sample data to demonstrate proof of concept that CMS could use information exchanged through the CMS data element library and the PASSIO project's IGs to automate collection of existing measured data and potentially develop new clinical quality measures in the future. The PASSIO project added to the existing use case for the September 2020 and January 2021 HL7 Connect-a-thons to test the reporting of the hospital ECQM quality measure stroke for thrombolytic therapy. Ultimately, the PASSIO project IGs have the potential to facilitate provider-to-provider information exchange between providers and CMS for quality reporting and payment purposes, and information access for the patient and her family or caregivers. The HL7 January 2021 Connect-a-thon use case featuring functional and cognitive status spans 5 scenes covering home and community-based services, acute care, post-acute care, and patient and family access. It follows the story of a patient named Betsy Smith Johnson, diagnosed with multiple chronic conditions, who experienced an ischemic stroke and must continue her recovery through multiple care settings. This high-level overview shows how the patient information flows as the patient transitions between care settings. It begins with the case management system associated with the home and community-based services, transmitting patient information, including ELTSS, long-term services and supports, care plan, patient goals, advanced directive information, and medication diagnoses and treatment the patient received prior to hospital admission, collected through the health information exchange to the hospital system. The hospital system can use the PASSIO functional and cognitive status IGs to submit select information necessary to calculate and submit ECQMs to CMS to satisfy quality reporting requirements. Then the hospital system can transmit all records received from HCBS and new medications, diagnoses, or treatments received while at the hospital to the skilled nursing facility through the Health Data Manager Central Repository, which in a production environment could be a health information network or maintained by a vendor. Next, the skilled nursing facility can pull the latest MDS assessment instrument from the pseudo DEL data element library, complete the assessment at the required time points, and submit the individual patient responses to both the prototype quality reporting assessment system and to the health data manager, so the next care setting, home health, also has access to that information. The home health agency can then also pull the latest version of the OASIS assessment instrument, complete it at the required time points, and submit the individual patient responses to both the prototype quality reporting assessment system and to the health data manager. Finally, the patient and her family can access all of this information in real time using a web or mobile app that connects with the health data manager. This diagram is a more detailed description of how the patient information flows as the patient transitions between care settings, including the 5 implementation guides used to support the data exchanges and the individual clients and servers involved within each care setting. In conclusion, the FHIR standard establishes a fast, efficient, and flexible common language and process for all health IT systems to communicate, allowing information to be shared seamlessly and efficiently. FHIR APIs enable the exchange of specified information from a large amount of data using request and response commands. HL7 provides a comprehensive framework and related standards process for the exchange, integration, and sharing of electronic health information. CMS and ONC are promoting interoperability through policy initiatives encouraging use of FHIR. And the PASSIO project has been developing FHIR implementation guides to facilitate health data exchange across all healthcare settings and to enable patient and family access to health information. At the end of this deck, you will also find additional information on where to access more information about the interoperability policy and data element library resources, the Dell FHIR API, and the PASSIO implementation guides and reference implementations. Thank you, and I hope this has helped provide more information. Any questions?
Hey, this is Saima. If you have any questions, feel free to post them in the chat as well, if you don't feel comfortable speaking up.
Yeah, if there is anything anybody would like me to go back and review, like, to the cake slides or wherever, I'm happy to kind of go back so you have it in front of you.
Jessica, just JB, I had a question 1 or 2 slides back where you have the deeper architecture where the flow from the care management system all the way to the home or home care. Yes. If the patient has a remote health monitoring system, could be in the nursing home or could be in the home, how would that get integrated if there is such a point that could be added? And that would be wireless blood pressure. It could be a wireless thermometer.
So we've actually been in discussions with a group that works on those kind of monitoring devices within CMS, but we have not to date incorporated that type of content. I think that would be an opportunity for collaboration down the road. I think that, I think in our discussions with them, they have not, to my understanding, yet developed an implementation guide that, would define the exchange processes for that information. So we've talked about working with them to develop such an IG or to, wait for them to have developed one and then try to integrate it into our other, our use case with all of our other IGs. But at this point, because there is not an implementation guide that currently deals with that type of content, we can't really plug it into this use case. Dave, is there anything you would like to add to that?
Yeah, so I mean, so there's a group that's working on a patient-reported outcomes, in which case that might fit into some of the work that a remote device might use. I think how it would fit into this diagram, it could fit into it a couple of different ways. One is it could, that information could go directly to the health data manager, in which case then everybody could pull it out. The other thing is it could, if, for example, this is a remote offering, a remote monitoring device for a particular, hospital or skilled nursing facility or whatever, it could go directly to that EHR system, and then hopefully also in this particular architecture go to the health data manager so that everybody gets access to it. In this particular architecture, the health data manager is the sort of the central source of truth. It allows, no matter where the patient goes in their journey, that information is available. So we don't have, point-to-point, necessarily point-to-point, conversation or point-to-point transitions between providers. So everybody sort of ties into a single, health data manager in this case. There's advantages and disadvantages to each type of architecture, but those are the ways that, at least for this architecture, that I could see it working.
Juby, again, just a follow-up on that. So we, in the initial, and stay here, Jessica, in the initial, we mentioned a brief mention of TEFCA, which is, a hidden blockchain, I guess you want to call it. Is there any linkage or interconnectivity here within the space or in the future with TEFCA?
So currently TEFCA, we're not tying in to any particular TEFCA organization. Perhaps the only one that I think might fall into that category is MyHIN.
Mm-hmm.
But otherwise, we're the other transitions that are going on are not necessarily going through a TEFCA network per se. That is something we could look at doing in the future, but that's not what's happening now.
Thank you.
Mm-hmm. I mean, there's lots of different things we can pursue. There's tons of different ways that this could go in the future. So it's exciting.
This is amazing. Thank you so much. Really, it is a very nice, insightful presentation. Very helpful.